Shall we start, sir? It's 9
Yeah.
o'clock.
Yeah, please.
Good evening, everyone. Today's subject seminar is regarding surgical site infection. Now, as surgeons, this is something that we just can't run away from. Every incision that we make has a potential risk of developing a surgical site infection. Although we can't run away from it, the idea should be to avoid it as much as possible. And this is something that we're going to look at in the talk today by Praveen. And so without any further delay, Praveen, can please start off.
Yes, sir. Good evening to respected teachers and colleagues. Today's topic is on surgical site infection. Today we'll be discussing about the surgical wounds, type of wounds, its classification, and different surgical site infections, and what are the guidelines to prevent these infections. What is an infection of a wound? It is invasion of organisms into the tissues after a breakdown of local and systemic host defenses. As there was a confusion between the wound infection and from surgically formed wound infection, in 1992, CDC revised the definition of surgical site infection as an infection related to surgical procedure that occurs near the surgical site within 30 days following the surgery or up to 90 days when an implant is involved. Surgical wound can be classified.
If I can stop you for 1 second, can just go back to the previous slide. This was, I think, when they came up, I think the latest guidelines is that up to 1 year when an implant is involved, as far as my knowledge goes. Okay. And the second thing is, can any of the postgraduates, Nikita, if you're there, we keep talking about this word infection. Can you define infection of a wound? Nikita, are you there? If not Nikita, then Vinod.
Hello, sir.
Yeah, tell me, Vinod. Like we keep talking, no, infection, wound, infected. Define infection.
Invagination of an organism leading to pathology, abnormal pathology.
Fine, that is a theoretical. Practically, what do you do? Like if you're doing a study, we're going to say, let's look at the incidence of surgical site infection.
Okay.
Define the word infection based on CDC guidelines, if you can. Praveen has this answer later on, but I want you guys to know that this is important.
Erythema, inflammation, pus.
Okay, I want all of you to give me the answer next. Indraja, and then after that, Pawan.
Sir, that can lead to like fever and tachycardia, sir, and locally patient will have the swelling, erythema, and local rise of temperature, sir, or any discharge from the wound.
Praveen?
Sir.
Yeah, same thing.
Sir.
Same question.
Yes, sir.
Is there something extra you want to add on, or is it the same answer?
Same answer, sir. I'll be covering next.
No, not
Sir,
Praveen, sorry.
I
Pawan. I want to ask
I
Pawan
would like-
actually. Yeah, Nikita, go on.
Sir, gaping of the wound and non-healing of the wound, sir.
Okay. Pawan, are you there?
Yes, sir.
Yeah, would you like to add anything extra to what has been said so far?
Sir, already Indraja explained signs of inflammation and any pus discharge is there.
Okay. Once we get to the slide, this is like a pre-test. I've asked you guys what the definition of an infection as per CDC guidelines is. So once Praveen gets to the slide, you'll have the answer. There are 3 separate points that has to be looked at for a definition of wound infection. Okay. Praveen, please carry on.
Just 1 sec, Nishant. The reason Nishant asked this question is very important. All of us who report on incidents or treatment or outcomes in surgical site infection or wound infection must be on the same page. So you saw 4 different people give 4 different answers. And so if all the researchers or people who collate data do that, then there is no uniformity. So when the slide comes, you will know the answer. All of us must clearly understand that and stick to that even in clinical practice. That is the important thing. Go on.
Thank you, sir.
Before going to the infection, let's see about the surgical wound classification. It is classified into 4 types as clean, which is class 1, in which it is an uninfected wound which has no inflammation and is closed primarily. In this type of surgeries, no respiratory, gastrointestinal and urinary tracts are not entered. So there is no breakage in aseptic technique, and the infective risk is very low, that is less than 2%. In clean contaminated wounds, there will be an elective entry into the respiratory gastrointestinal systems with minimal spillage of the fluid. There won't be any major break in aseptic technique such as appendicectomy surgery, and infective rate is around 10%. In contaminated wounds, that is class 3, there is non-purulent inflammation and there is gross spillage from the gastrointestinal tract. Or if any penetrating wounds came within less than 4 hours, it is classified as contaminated wound, and there is chance of 20% of infective risk. In dirty infected, that is class 4, there is purulent inflammation present, and there is perforation of viscera and the penetrating trauma wounds which came after 4 hours, and the infective risk is of about 40%.
Yeah, 1 second. Nikita, if you're there, can you please give me one example of each of these classification of wounds apart from what is mentioned there? Something that we routinely do. For clean, can you give me one example?
Clean is an incision, sir, like on a skin.
Example of a surgery. Surgery where
Surgery,
we,
sir. Sir,
where we
lipoma
don't come
excision.
across. Pardon me?
Lipoma
Excellent.
excision.
Excellent. Something much more simple. Breast, thyroid. We don't enter into any important tubular structures. Just keep that in mind there. Okay. Next,
Yes,
we
sir.
know for clean contaminated. Anything apart from appendicectomy that we routinely do?
Sir, laparoscopic cholecystectomy. I'm still there. So clean contaminated.
Correct, no.
Yes, sir. And
Yeah,
contaminated is
cholecystectomy is correct.
contaminated is the spillage in case of hemicolectomy, sir.
Correct. Uncontrolled spillage.
Yes, sir. Gross spillage,
Okay.
uncontrolled spillage.
Okay. And dirty infected. Forget
Any
about the abdomen. Something
perforated.
else. Something else. Forget about the abdomen. Anything else where you can.
Perianal abscess, sir. Perianal abscess, would it come under that, sir?
Okay, accepted. Necrotizing fasciitis, gas gangrene,
Yes.
all these will eventually come under dirty infect.
Okay, sir.
Okay, yeah. Go on, Praveen.
To assess the wound, we have asepsis wound score and Southampton wound score. The factors responsible for the development of surgical site infections are: what is the degree of microbial contamination of wound during the surgery, and how long was the procedure done, and what are the host factors. And it includes the patient factors such as old age, immunosuppression, obesity, diabetes mellitus, malnutrition, smoking, anemia, and local factors such as poor skin preparation, contamination of instruments, inadequate antibiotic prophylaxis, prolonged procedures, local tissue necrosis, hypoxia, hypothermia, and microbial factors such as duration of hospitalization, toxin secretion, and resistance to the clearance. Among the wound infections, the major part is by the Staphylococcus aureus, that is 29%, followed by coagulous negative staphylococci 20%, followed by enterococci 17%. And surgical site infection can be classified as superficial incision, deep incisional, and organ space incision. Organ space surgical site infection. And CDC has given guidelines to define each of these. Superficial surgical site infection is when the infection occurs within 30 days after surgery, and it should involve only the skin or subcutaneous tissue. And at least one of the following of the category presentation should be there, which is purulent drainage, organisms isolated from the fluid or tissue of superficial incision, at least one sign of inflammation, or wound is deliberately opened by the surgeon, and surgeon or clinician declares the wound as infected.
Yeah,
Here-
one second, Praveen. Can you go back one slide? So, like we said, this is the definition of any wound infection as per CDC guidelines. All right, there should be pus. If not pus on your wound culture, you should isolate some or the other organism from a tissue fluid, not from the surface of the skin. And the third one actually is when the surgeon deliberately opens it. All right, you know there is a collection underneath, but there is no pus coming out, nor can you develop a culture because the skin is intact. So the surgeon will deliberately open it in order to release any collection underneath. That is the third point to define a wound infection. Go on, Praveen.
Yes.
If, sir, I have one question.
Yeah, please, Abdul.
So if wound is open for seroma, then nothing, not considered.
Provided the surgeon thinks it's an infection. Because they said, no, there'll be signs of inflammation, presence of erythema, swelling. If there is only erythema or swelling, we don't consider the wound infected. It can still be inflammation.
Okay, sir.
Okay, but when the
Abdul.
surgeon is convinced that there is infection, he opens up the wound in the presence of any of the signs of inflammation, then it falls under the category of wound infection.
Abdul,
Yes, sir.
sorry to say, but if at all you are suspecting seroma, why do you open? You don't open the wound. You just aspirate the seroma if
Yes,
it is required.
Yes, sir.
So you don't open the wound. Only when you suspect infection, only then you open the wound, right?
Yes, sir.
And what are the wounds that is not considered superficial surgical site infection? Or if a stitch abscess and infection is at episiotomy site or at circumcision site or a burn wound, or if superficial surgical site infection extends into the fascia or muscle, these types of wounds are not considered as superficial one.
Praveen, can you tell us why it's not considered an SSI for each of these criteria?
Sir, as in stitch abscess, will not be opening the wound, sir. And
Okay, simple. Go
sir,
back to
yes,
the,
sir.
I mean, don't have to go back the slide. In the previous one, you said, no, there should
Yes, sir.
be either
Purulent.
organism which comes out. Stitch abscess
Yes,
is
sir.
because of a foreign body reaction.
Foreign body, yes, sir.
Okay, so it's not technically infection. It's the host response to a foreign body within the body of the skin. Within the body.
Body, yes, sir.
The second point, episiotomy, circumcision of burns.
Sir,
Sir, I honestly don't know the answer to this. If any of the seniors can tell me, because I looked up for it, but I couldn't find. I assume because he's put it up, he knew the answer.
no, sir, actually, I do have that doubt, sir.
I don't know either, but I can only guess that these are not considered regular surgical procedures. You know, I mean, circumcision is a regular surgical procedure. Episiotomy, you know, I would consider, a surgical procedure, but I don't think in the definition they want to, they want to exclude it as a surgical procedure. But this is conjecture. I honestly don't know why they have.
My guess would be,
Yeah,
because they are in an area which are, sort of thought to be a very contaminated areas. Probably that is why they don't consider this as infection. Because if you do swab there, you will probably grow something anyway.
yeah.
Because
I mean,
they are.
see, but that applies to other areas also.
Even
I mean,
contaminated
oral
surgery.
cavity, for example, axilla, the groin, they're also infected, but there it is not considered. That's why I sort of had a doubt about that. Yeah, I'm not sure, to be honest.
I think that is
Right. Go ahead. Go ahead.
Yes.
And just
But this is a CDC definition, I know.
Yes, sir.
Yeah,
From the
okay,
CDC guidelines.
okay.
Sir, and another point to be mentioned in from now on, any either superficial or deep, it's again further classified into primary and secondary. Praveen, can you tell me what that is? Do you know what it is?
Sir, no, sir.
Anybody else?
Sir.
Pawan?
Sir, what I'm thinking is primary means at the site of the incision or a wound. If you isolate any organism,
Okay,
then
secondary.
secondary means some. Sir, I don't know exactly, sir.
Okay, so basically primary means if it's only a single incision or the main incision. Okay, when I say main incision, for example, a CABG, you're going to harvest graft from the leg, but do the surgery in the thoracic cavity. So that time the thoracic cavity incision becomes the main incision. Okay, so if the infection is in the leg at the main incision, or if it's a single incision, it is called as primary. Secondary is if the donor area, like from the leg, if they're harvesting the graft, that area gets infected, it's called as secondary infection. So this is applicable for both superficial and deep infection. Go on, Praveen.
Yes. And deep incisional surgical site infections includes infection which occurs within 30 days of surgery or within 1 year of an implant. And it involves anatomic structures that are not opened or manipulated during the surgery. And it should include at least one of the following criteria, such as purulent discharge present from deep incision, but without organ or space involvement. And if there is any facial dehiscence or fascia deliberately separated by the surgeon because of the inflammation, or a deep abscess identified by direct examination or during reoperation by histopathologist or by radiological examination, or the surgery or clinician declares that it is a deep incisional infection. Organ or space surgical site infection includes when infection occurs within 30 days of operation or within 1 year of an implant, and it involves anatomic structure not opened or manipulated during the operation, and it includes at least one of the following, that is purulent discharge is present from a drain placed by a stab wound into the organ or space, and organisms are isolated from the organ by aseptic cultural technique. An abscess in the organ or space that is identified by direct examination or during reoperation or by radiological examination, or diagnosis of surgical site organ space surgical site infection is made by the surgeon or clinician.
Okay, just to sum up whatever he said, there was a lot of definitions involved there. The definitions are very important if you are for everything, okay, even in clinical practice, to identify it, to report the infections and all. But to make it easy, let's assume you're operating an open appendicectomy for an appendicular abscess. After surgery, if only the skin is infected, you call it as superficial skin infection. If the infection is beyond the level of the deep fascia, that means if either the muscle or the deep fascia is involved, or if there is a wound dehiscence because of infection, it becomes a deep infection. Or if there is an abscess at the level of the appendix, in spite of you giving a wash, there is a residual abscess left, or a residual abscess or a new abscess which is formed in the area, then that becomes organ space infection. Please carry on, Praveen.
Yes, sir. For the prevention of surgical site infections, many guidelines had been made. Among them are National Institute for Health and Care Excellence UK guidelines in 2008 and updated at 2013, Infections Disease Society of America guidelines at 2014, WHO guidelines on 2016, and CDC guidelines at 2017, and Asia Pacific Society of Infection Control at 2019 for the preoperative, intraoperative, and postoperative phase of the surgery. Now, as WHO guidelines are followed widely, we'll be discussing about the guidelines of WHO. Preoperatively, whether preoperative bathing is necessary or not. It is the guidelines are, it is good clinical practice for the patients to have a bath or shower prior to surgery by either a plain or antimicrobial soap.
Can you tell me why, Praveen?
Sir, just to prevent endogenous bacteria into the wound sites, sir.
Yeah, so normal skin itself will
Skin
have
flora.
certain bacteria which are commensals for the skin. Okay, but if the same, because at the level of the skin, based on the environment, they act as commensals, but the minute they go inside, they no longer act as commensals. Okay, there can be colonization which can be pushed in during surgery. That's the reason preoperative bathing might help reduce this bacterial load.
Praveen, but how would a bath with a plain soap deal with bacteria? They say they don't insist on an antimicrobial soap. The answer is
Sir,
that it is designed to take away particulate matter from the area of
Oh.
the surgery. Okay.
Okay,
Focus is not on bacterial
Yes.
clearance, but on taking away muck from the
Yes, sir.
surface of the skin. That is the main focus. Yeah. Go on.
Yes, sir. And if mupirocin ointment should be applied preoperatively, it should be applied preoperatively in the patients undergoing cardiothoracic or orthopedic surgery with no nasal carriages of staph aureus, and it should be given preoperatively as 2% ointment. And there is also consideration, conditional recommendation to consider in patients with undergoing other types of surgeries having nasal carriages to apply intranasal application of mupirocin 2% ointment.
Yeah, so just to clarify, this is intranasal application of mupirocin, not on the abdomen or the level of the skin. Okay, and this is only recommended for cardiothoracic or orthopedic surgeries, not for general surgeries.
What are the optimal timing for preoperative surgical antibiotic prophylaxis? It depends on the type of operation, and it should be given within 120 minutes before the incision, considering the half-life of the antibiotic.
Okay, 1 second. Just stop, Praveen, before you go to the next
Yes,
slide.
Yes, sir.
Vinod,
Yes, sir.
can you tell me the principles of giving surgical prophylactic antibiotics? First, what is the choice of antibiotic you want to give?
Mostly, generally, if it is a incision, if it is superficial, if we are giving a clean surgical site, then we can go for which covers mainly gram-positive organisms, sir.
Just give me the answer of an antibiotic which you want to give.
Sir?
Which antibiotic? Name the antibiotic.
Cephalosporin, sir.
Which generation? First, second, third?
Second generation.
Okay, the answer is first generation cephalosporins, whichever has a broad range of coverage. Second point is these antibiotics should not be used as therapeutic antibiotics. Okay, so what I'm trying to say is, like, for example, if you're going to use amoxiclav, okay, amoxicillin clavulanic acid, you are augmented. Okay, because you're using that as therapeutic antibiotic, it is preferable to avoid using that as surgical prophylaxis. Okay, don't mix prophylactic antibiotic and therapeutic antibiotic. Second, what class of wounds would you like to give these prophylactic antibiotics for? You have no clean, contaminated, and dirty wounds?
Clean, contaminated will start.
Why not clean cases?
According to the studies, there is no difference in with and without antibiotic.
Okay, I'll give you a scenario now. For an inguinal hernia, do you give antibiotic or no?
No, sir. Clean.
Pavan?
Sir, you have to give, sir, in case
Why?
of inguinal hernia or any
Why?
implants.
That is the answer. Okay, so the indication for giving prophylactic antibiotic is clean case with an implant. Okay, clean case without an implant, you don't need to give. Theoretically speaking, for breast, thyroid, lipoma, or soft tissue sarcomas on the skin, you don't need to give prophylactic antibiotics. They're clean cases. But whenever you're using clean case with an implant, like a hernia with a mesh, or even orthopedic surgeries where you're putting implants, all these come under clean cases with an implant. So you have to give prophylactic antibiotics there. Okay. And of course, clean contaminated. For contaminated and dirty, prophylaxis doesn't come into picture. It becomes therapeutic antibiotics at that point of time. All right. And third point, it's written wrong here. Within 120 minutes is acceptable, but with what is the ideal time you want to give the antibiotic?
1 hour.
Why? Why is that cut off 1 hour?
Sir, by the time of incision, so the antibiotic action will be peak at that time, sir.
Correct. So in the blood, the level of the antibiotic is at the highest. All right. So that is the reason we prefer to give it 60 minutes. Then why is this 120 minutes? He's mentioned, no? The answer is also there only. Second half.
So
Half-life.
T off depends on T off.
Correct. So if there are certain antibiotics like vancomycin, which they use for neurosurgery, that time these antibiotics are given 2 hours prior, so that it actually takes 2 hours by the time it reaches the peak. Okay. So this is the first half of prophylaxis. What is the second half? Is it only 1 dose, 2 doses, 3 doses, 4 doses, 5 doses? How much is it?
Sir, greater than 4 hours, we'll give another dose, sir.
Okay, that is okay. That wasn't my question. When do you stop the antibiotic? Okay, I'll make it even more straightforward. Pawan?
Sir,
Within
usually,
24 hours. Within 24 hours.
sorry, okay, sir.
Okay, so if you start, you can give up to 2 or 3 doses also, depending on the half-life or the duration of the antibiotic, the dosage of the antibiotic. You can give up to 3 doses within the 24-hour period and stop. It is still considered as a prophylactic antibiotic. Okay. And that second point, you said after 4 hours you want to give. What is that 4 hours?
After first dose, sir.
4 hours of what?
If surgery prolongs.
4 hours of duration of surgery. Okay, that is because you are exposing the wound to the environment for such a long period of time. So that is when they expect you to repeat the dose of antibiotics. I think it's 4 or 6 hours. I'm not very sure.
4 hours.
More
Okay.
than 4 hours.
4 hours. Okay.
Yes,
4
sir.
hours.
Done. So we spoke about first generation cephalosporin and vancomycin. What about anaerobic cover? What antibiotic would you like to give?
Nishant, can I just, see,
Yes,
usually the universal prophylactic agent is cefuroxime, which is a second generation, not first generation. It is a second generation cephalosporin. And the students, please note that you guys continue to give cefuroxime even if it is beyond 24 hours. Please don't do that. You will have to change. If you think that inside, when you go in, for example, you are thinking it's a straightforward gallbladder or a straightforward appendix, but then there is either an abscess or a collection or empyema of the gallbladder or whatever, you need to continue. Then you have to switch from cefuroxime to ceftriaxone or any other antibiotic, but do not continue cefuroxime, because you want to maintain the efficacy and the inhibitory ability of a prophylactic antibiotic. So you should not continue that if you are thinking that you need to continue beyond 24 hours.
Yeah. Thank you, sir. Yeah. So like I was saying, for anaerobic cover, you need to add metronidazole also along with your cephalosporin. And so please understand that prophylactic antibiotic is a huge class by itself. But because there was a question, we just wanted to cover it through a rapid revision. Okay.
Sir,
Yeah, please go on.
So with an
I have a question.
Yeah,
I have
please
a
ask.
question, sir.
Yeah.
Sir, with an implant, is there any recommendation to start before the surgery for elective surgeries?
With an implant, is it?
If a patient with an implant or prosthesis, sir, is there any recommendation to start before the surgery?
No, only if you are
Antibiotic.
putting an implant, it becomes necessary. If he already has an implant, like he has a previous hernia surgery and now he's come for thyroid surgery, you don't need to give him antibiotics.
Okay.
Sir,
Abdul, you had a doubt.
So for with an implant, after 24 hours, we should still continue, or 24
Not
hours?
necessary. Not
24
necessary.
hours is fine.
If you want to give for some reason, like let's say you're planning a gallbladder and a hernia mesh repair, okay, you, no matter what you do, by chance there is a bit of extra spillage in the gallbladder. Now, to be on the safer side, you want to give antibiotics for 3 or 4 days. It no longer comes under prophylactic antibiotic, it becomes therapeutic. Or for some reason, let's assume the patient is immunocompromised, like the nodular liver or kidney CKD patient. So that time, again, prophylactic antibiotic, you want to give them therapeutic dose for 3 days or 5 days.
Okay, sir.
If you want to call it prophylactic, it has to be stopped within 24 hours.
Sir, since Supacef is a second generation cephalosporin and has broad spectrum of anti, you can continue that as a therapeutic also.
No, see, this is
Not
what I
always.
keep telling you.
Yes, sir.
You cannot do that because you want to maintain its ability. See, the prophylactic antibiotic you should never develop resistance to that. So if everybody does this, then there is a good chance it has actually remained a prophylactic antibiotic for at least 2 decades now. So I think we'll have to, continue that. And that is why if you are thinking of therapeutic, you switch to another second generation or a third generation cephalosporin.
Okay, sir. And like whether it also depends on the flora of the OT also, sir, like the prophylactic antibiotic. It also depends on
OT has to be a negative culture before you operate. It's as simple as that.
OT has got nothing to do with it. It is just the cover that you give.
Site of surgery matters. Yeah.
Ideally, Nishant, the prophylaxis is, preferably mentioned as 1 dose. But as you said, it can be extended up to 3 doses within 24 hours. Ideally, one dose.
Yes, sir. Go on, Praveen.
And these are the common surgeries and the expected pathogens during the surgeries.
Yeah, we have covered this. You can go on.
Yes, sir. And regarding the mechanical bowel preparation, as we have seen earlier in the ERAS procedure, it has no separate value. But if mechanical bowel preparation is done, it should be done along with the oral antibiotics only. It should not be done alone.
No. Mechanical bowel preparation, no. It does reduce surgical site infection, but it has no impact on the healing of the anastomosis.
Healing of the anastomosis, yes.
Yeah. Please don't get that confused. Why MBP alone should not be used? Why should you compulsorily use oral antibiotics? Anybody? Indraja?
Sir, mechanical bowel preparation, we may lose the normal gut flora, sir.
No, that I understood. I'm saying if you're using mechanical bowel preparation, they recommend along with that you use oral antibiotics as well, like Rifagat or something of that sort. Why is that? Why not only mechanical bowel preparation? The second point in this slide mentions that should not be used.
Yes, sir.
Basically, what happens when you give bowel preparation, the bowel is loaded with liquid feces. And in liquid feces, the amount of bacteria is a lot more when compared to solid feces as well. Okay?
Yes.
That's the reason they say you give oral antibiotics which go into the gut and act there and at least kills off the bacteria to reduce the bacterial load.
Okay, sir.
Okay? Yeah. Go on, Praveen.
Whether hair removal should be done or not. Under the guidelines of WHO, hair should not be either removed or if absolutely necessary, it should be removed only with a clipper. Shaving is strongly discouraged at all times, whether it is preoperative or in the operating room.
Nikita, can you tell us why shaving is discouraged?
Sir, it actually disturbs the surface of the skin and it could cause the infection, sir.
More than that. Okay, 1 point, accepted. What happens when you use a razor?
Micro aberration, sir.
We can be macro also, because you're not shaving yourself. No, somebody else is doing the parts preparation for you. So it will not be as tidy as how you would do it, or as careful as how you would do it for yourself. Okay. So that's why they say ideally is not to remove hair at all, unless it comes in the way of your surgery. If you have to remove it, the recommendation is it is done on table after induction with a clipper. Okay, so that you don't cause any aberrations. And second thing is, when you scrape it, whatever bacteria is at, let's say, at the base of the hair follicle or something, will start coming up to the level of the skin. So by the time you put an incision, actually the risk of infection is higher, because the bacteria would come to the surface of the skin.
Just on a lighter note, Nishant,
Yes, sir.
I had a patient who had a large disc tumor in the right colon. Patient actually had traveled from Udupi and he was actually fine, though there was, because it was about 20 centimeters, this tumor, and somehow they traveled and without any problem. And unfortunately, in their enthusiasm, the ward put him on his prone position to shave his back and everything, and that ruptured the disc tumor. So there are other, collateral damages that can be done by shaving. So please do not, I think all our surgical patients, no preparation in the ward. That should be the default setting. No preparation in the ward. If you need preparation, we'll do it in the OT with clippers.
Thank you, sir. Any questions so far before we go ahead?
No, sir.
Okay. Lakshman sir, anything to add, sir?
No comments. No comments.
Yeah.
Going on.
Carry on, Praveen.
Yes, sir. And surgical site should be prepared by alcohol-based antiseptic solutions, or which is based on chlorhexidine gluconate for the surgical site, and whether antimicrobial skin sealants should be used or not.
No,
This,
go back one slide. Go back one slide. Indraja, tell me one alcohol-based solution that you use normally.
Generally, we'll use a betadine solution.
No, I'm asking you, tell me one alcohol-based. Betadine is not alcohol-based, no, that's iodine-based.
Yes.
What do we use alcohol-based? Some swab we use now. What is it called? Before putting IV cannula, what do we use?
Sterilium.
Spirit.
Sorry, sir. Spirit.
That is an alcohol-based solution. Chlorhexidine is a chlorhexidine-based solution. Now, why do we not use only spirit? Why do you always have to combine an alcohol-based antiseptic along with chlorhexidine?
I'm not sure.
Okay. Anyway, alcohol it acts fast, but the action is very limited. Okay. But let's assume you have a surgery for a prolonged duration of time. Your alcohol-based antiseptic will not maintain antisepsis or asepsis for such a long period of time. Your chlorhexidine will give you a prolonged effect. Okay, so that's why it's a combination of alcohol and chlorhexidine. And studies have shown that it is using betadine is also equivalent of using chlorhexidine. Okay,
Yes.
Vinod.
But Nishant, is not chlorhexidine better than betadine?
They've said it is equivalent. Few studies have said chlorhexidine is better, sir.
Yeah, chlorhexidine is generally considered better. Even polyvinyl, purely,
Chlorhexidine went into disrepute because it became a good culture medium for Pseudomonas because it was stored. So the recommendation is, and it has made a comeback since we are using fresh solutions, chlorhexidine is considered better.
No, the Pseudomonas, I think, was with cetrimide, Savlon. Chlorhexidine, one of the theoretical issues is that because it is alcohol-based, it has a higher flaming risk with cautery. Okay, so that doesn't happen with povidone iodine.
Vinod, normally we paint and then drape. Why can't we drape and then paint? Did you understand the question?
Time
Of what?
for at least 2 minutes it requires for a
What is that called? Contact period.
contact period. Yes.
Okay, that is the minimum amount of time needed for that particular solution to take effect. So you paint, you drape, you'll roughly take so much time. So why I'm telling you this is, after painting, draping, and you're ready, don't take a mop and wipe off the bedding. It has to dry there. Okay, for all postgraduates, don't take it, wipe it off, take spirit to clean that area well. You're actually undoing whatever good thing you have done so far. Okay, if at all you want to use spirit first. On top of that, you use betadine. Okay, and don't allow pooling of either spirit or, like sir said, chlorhexidine, because there's a chance you can have fire hazards inside the OT. Yeah, go on, Praveen.
Whether antimicrobial skin sealants should be used or not, according to WHO guidelines, there is no quality of evidence for the usage of antimicrobial sealants at the surgical site infection, surgical site preparation.
Okay. One second. Question. Oh, you had something to finish. Yeah, tell Praveen.
What is skin sealants? It is an sterile film forming cyanoacrylate based sealants. After applying on the skin, it forms a layer and it prevents the endogenous bacteria contaminated into the incision site, and it dissolves slowly within a few days, sir.
Excellent. He's given you half the answer to my question, which I'm going to ask now. Pawan.
Sir.
He said no, antimicrobial skin sealant means it's cyanoacrylate with some amount of antibiotics on it, and they're going to use it.
Yes, sir.
How is this different from just applying the skin ointment? Skin ointment is also an antimicrobial which I'm applying over the wound. How is this different?
Sir, absorption, sir, it has to be.
Yeah, partly correct. See, the thing is, like he said, skin sealant, it gets absorbed over a few days, or it gets dissolved, or biodegradation, whatever happens, it's over a few days. So till such time, the antibiotic is held in place over the wound. Whereas your ointment, there's a chance that your dressing, when you remove the dressing or when you wipe it off, it'll get washed off or it gets wiped off from that area. Okay, so that is the difference between a skin sealant versus just applying an ointment. Go on, Praveen.
Nishant, can I ask you one question?
Yes,
This
sir.
Ioban and other are they useful at all?
No, sir. The studies have shown that they does not prevent any surgical skin infection. I mean, no difference in infection rates.
But orthopedic and cardiac surgeons continue to use it.
They are scared of infections, sir.
Yeah.
We thrive under infections. They scare.
Sir, one thing is there, sir, like that Ioban induced for laparotomies we use, no, sir.
Yeah.
It is comparatively less cheaper. It is cheaper to that 4 drapes we put, no, sir, together. That single drape of Ioban with the thing is cheaper than the 4 separate drapes we put.
No, but we do use the drapes as well. It is not there either. It's not either or.
You can't use only Ioban.
No, not only Ioban. Ioban along with the drape it comes. It's a single package. Nowadays, in Sagar we have Ioban along with it's a full body it will cover. But that is cheaper compared to the 4 individual we put, no, sir.
Okay.
I think this is 1,800, the single one, and this thing is 500, 600 each, so around 2,400 or something.
Okay.
Very nice. Thank you. I didn't know this. Anyway, in where we use reusable drapes, towels.
Yeah, towels, yeah.
So finance is probably not our strongest forte at that point of time. Go on, Praveen.
Sir, why should not use this sealant, sir?
You can use them, but I'm saying that it does
not useful.
Okay. It's not useful. It's
very
okay.
Low quality of evidence.
Yeah, the wordings doesn't mean that you should not use, means they should not use for the purpose of reducing. Just because you use this, don't assume infection will come down. That is what the sentence means.
Okay.
Even if you use skin suture, it is as good as using an antimicrobial skin sealant. That's all.
And surgical hand preparation should be either performed by scrubbing with a suitable antimicrobial soap and water, or using an alcohol-based hand rub before donning the sterile gloves.
Nikita, which is better?
Sir,
I'm only asking
dry
this because
scrubbing
I
is
know
better,
you know
sir.
the answer.
Yes, sir. Dry is better, sir.
No, okay. Okay.
Without
How?
water.
Why? Why? Why do you think dry is better?
Sir, water might have some microorganisms. I mean, we are not sure how clean the water are.
No, that's not the answer. Both of them are the same when it comes to in terms of incidence of surgical site infections. But when you do a dry rub, you're saving a lot of water. Because if you're using a regular wet rub or a hand wash, you're not supposed to switch off and switch on the tap in between unless you have an assistant to do that for you. So the water is continuously running. So you tend to use up about 20 to 30 liters of water per wash. Okay, every time you wash for the case. Whereas in a alcohol-based hand rub, you can save that much water. That's all. So in that way, it's better. Not in terms of incidence of skin infection. They are the same. Go on, Praveen.
And WHO also advised for the water rub when hands are when there is visibly soiled. Otherwise, you should use the hand rub.
Correct.
And this is the procedure for the hand wash with water, and this is the steps for the hand rub.
They are the same. Six steps, 6 times.
Yeah.
Go on, Praveen.
Yes.
I think,
And,
Nishant, I have to tell you that Sagar Hospital under Dr. Lakshman's leadership, we did a study and presented, and it got the Mahadevan Paper Award for this, replicated this. I think it's about 250 in either arms, I think. In the glow fluid culture, everything was done.
Yes.
And it showed no difference either in the, in the culture, organisms cultured from the thing, or in terms of superficial or deep surgical space infections in either of this group of patients.
Thank you, sir.
and in patients who are underweight and going major surgical operations, there should be consideration for administration of oral or enteral multiple nutrient enhanced nutritional formulas.
Why is this, Praveen?
So,
Your answer was in your second or third slide of your presentation. Simple, no? You had
underweight, so malnutrition.
That's all. That's all. So malnutrition is a risk factor for anything, even post-op wound healing, anastomotic healing, prevention of SSI, all these. So if you give him good nutrition, of course, your outcome or the chance of outcome will be much better at that point of time.
Can anyone say why they say that this is a very low quality of evidence? I thought the evidence was pretty strong, but if you are sure about this, why is that? Why is this low quality of evidence? Anybody? Indraja? Abdul?
I'm not sure, sir.
Sure.
See, because wound infection and things are multifactorial. So, you cannot just show this one factor to be the difference between whether the patient has infection or not. So that is why I think you may not be able to prove whether patient who is malnourished will have more surgical site infection compared to the person who doesn't. And then if by supplementing the nutritional support before surgery, would you be able to prevent it? It does make logical sense to do that, but I don't know whether you can, have a study where you can show only the, there will be so many other confounding factors. So it will be difficult to show that a cause benefit sort of relation. And Lakshman sir?
Totally agree with that. It's multifactorial, many confounding factors. So in many aspects of nutritional support, absolute proof for its use is really not available. But, there are indirect markers.
Markers.
SSI, mortality and morbidity, difficult to prove. But if you look at the markers for the use of or advantages of nutritional support, they are more easily demonstrable.
Continue, I think.
Thank you, sir.
Yes.
Go on, Praveen.
In intraoperatively, whether oxygen is required or not. According to the guidelines, adult patients undergoing general anesthesia with tracheal intubation should receive an 80% fraction of inspired oxygen intraoperatively, and if possible, in the immediate postoperative period for 2 to 6 hours for reducing the risk of surgical site infection.
Pawan, why is that?
Sir, oxygen delivery will be more, sir.
In order to prevent tissue hypoxia, local factors, avoid tissue hypoxia. That's a simple answer. So post-op, because they are just out of the ventilator, their breathing capacity and all will not be that great. So better to be on the safer side and give them oxygen. Go on, so that their respiratory effort will come down.
And it is advised for use of warming devices in the operating room during the surgical procedure for the warming of the patient bodies to maintain the normothermia.
Indraja, why does hypothermia cause? That's indirectly the implication of this sentence. Why is hypothermia a risk factor for developing SSI?
Sir, most of the organisms will grow at low temperatures. Okay.
No. Then why do you keep food in the fridge? Correct, right? Okay, simple. One is they hamper neutrophil function. All right, neutrophils tend to function at a certain temperature. So below that temperature, they don't work. Second thing is hypothermia causes vasoconstriction. So vasoconstriction means less blood supply, again tissue hypoxia. And why did you remember when we spoke about shock, we said something happens during hypothermia. What is it? It causes coagulopathy, okay, through various pathways. The enzymes don't function that well at a low temperature. So these patients can have a blood clot underneath the skin because of hypothermia or the coagulopathy, or the clotting doesn't happen that well. So any blood clot underneath the skin is a risk factor for wound infection.
Yes.
Carry on, Praveen.
And it is advised to follow protocols for intensive intraoperative blood glucose control for both diabetic and non-diabetic adult patients undergoing surgical procedures.
It should be less than 200.
200.
Yeah. Carry on.
And it is
What
advised.
is just go back. Intensive. Is that correct, Praveen? Intensive. I don't think there is any.
Yes.
See, there was a good, very good study from Holland where they were only cardiac patients, patients undergoing open heart surgery. I think there were 250 patients in each arm, which they showed that, patients who had minute by minute recording of their sugars and then, insulin accordingly, to people who were just monitored on a standard basis and then given insulin accordingly, there was no difference in terms of their infection rates or ICU stay or hospital stay and things like that. So I don't think there is evidence for intensive intraoperative blood glucose control is very tenuous. So I don't think there is any need for that. I think standard glucose control, obviously. I'm not saying you should have a sugar of 400 or 500. As Nishant said, get it below 200 and monitor it every 6, depending on the severity of the surgery, whether the patient was well controlled before and all that. Of course, these are customized for individual patients, but by and large, 6 to 8 hour monitoring, maybe in the first few hours, 4 hours or so, and then you can go on to 6 to 8 hours. I think that should be reasonable.
Yes.
Thank you.
And for the control of for volume control and to maintain normal volumia it is advised to follow the goal-directed fluid therapy intraoperatively. Goal-directed therapy, it is a strategy for optimizing the dose and timing of fluids, inotropes, vasopressors, by monitoring the cardiac output and other hemodynamic parameters so that there is adequate tissue perfusion and oxygen delivery to the organs and tissues.
At the end of the day, avoid hypoxia at the tissue level. Next.
Yes. And what types of drapes and gowns are advised? It should be either sterile, disposable, non-woven or sterile. Reusable woven drapes and surgical gowns can be used. We should not use the plastic adhesive incisive drapes with or without antimicrobial properties.
For the purpose of preventing SSI,
yes,
keep saying this,
yes.
people will ask why you should not use.
Yes,
So
for the
idea
purpose.
is, yeah, it doesn't give you any added advantage by using an antimicrobial, that with or without antimicrobial properties. Okay, go on.
And we can consider the usage of wound protector devices in clean, contaminated, and dirty abdominal surgical procedures for purpose of reducing the surgical site infections. And this is a wound protector device.
Correct. And the second thing is, it also doubles up as a wound retractor. Okay, those two rings that you're seeing on top and bottom, no? One ring goes inside the abdomen, the other ring goes on top. Then you go on tightening it till both the rings are pulling the abdomen apart. So it mitigates the need for a wound retractor.
And also as a extractor of the specimen.
Yes, sir.
After laparoscopic surgery.
Yes. And whether incisional irrigation should be given or not, there is insufficient evidence for recommending should be used or should not. It can be considered use of irrigation for incisional wound with aqueous povidone iodine solution before closure for purpose of preventing surgical site infection, particularly in the clean and unclean contaminated wounds.
Why is there low quality of evidence here? Nikita, can you tell me? Okay, tell me what happens, what are the downside of giving a wound irrigation?
No idea, sir.
There's a chance you can push the bacteria inside to the deeper layers. Okay, so that is the downside of it. But then again, normally we give only after you close the fascia and all that. That is when you give a wound wash or something to the level of the skin and subcutaneous tissue. Now, the studies say that antibiotics don't help. That is clear. Okay. So next will be, what is the choice of fluid? Do you want to use normal saline, DNS, RL? What do you want to use?
Normal saline, sir.
Why?
If you use DNS could be like growth medium for the microbacteria.
Not true. The idea is try to use something which is as physiological as possible. If you use a hypotonic saline, there can be cell lysis. Okay, so the skin becomes devitalized at the level where you're planning to suture. So the irrigational choice of fluid should be normal saline because it is as physiological as possible to your plasma in the body. Go on, Praveen.
Nishant, there was a very, lot of work on metronidazole with the thing and gentamicin with the saline. And I think a lot of people religiously used it. And as you said, there is no evidence to suggest that it made wound infections any less. So now the practice has probably been given up. At least I have stopped, using it for a long time. But
Yes.
sir?
We don't do any wound irrigation at all.
Yeah.
Not definitely.
No, even the abdominal cavity, when you have done a laparoscopy.
Cavity, if there is infection, we use it. It's what
Just saline.
Just saline is good enough.
Yeah.
It's a mechanical cleansing that's important.
Yeah, that's what I meant by
okay.
metronidazole and gentamicin.
Sure.
That right. I think you are in Aberdeen or Dundee, sir?
Aberdeen.
Aberdeen was the place where this gentamicin and metronidazole was started. I think, and one of my consultant called Douglas Stewart, he was a Aberdeen trainee. He was doing that very religiously.
Yeah.
Sir, with your permission, I think we just have another 5 or 6 slides. So probably 10 more minutes, I think we'll be done, sir.
Sure, finish it.
Yeah.
Yeah.
Go on, Praveen.
Yes, sir. You can use prophylactic negative pressure wound therapy in adult patients on primarily closed surgical incisions in high-risk wounds for purpose of prevention of SSI.
What is the concept behind this, Vinod?
Hello, sir.
Yeah. What is the concept behind using a prophylactic negative pressure wound therapy? That means using a WAC dressing.
It pulls out
What?
whatever
Right.
this.
That's all. Collection. You're reducing the risk of seroma, reducing the risk of some fluid being collected there, which has a potential of developing infection. And they also say that vacuum dressing, because of the negative pressure, will help neovascularization, or
Yeah.
it sucks the blood or more improve the blood supply to that particular region. But the point to be noted here is high risk wounds, okay, not routine.
So we know what are the likely wounds that you would actually consider using back therapy,
Dirty wound, sir.
right? That is frank peritonitis, where you don't want to close the skin. So you might either close it loosely, or so that the fluid has the ability to sort of escape out, or you can use vac therapy. Others,
Emergency traumas.
no, you don't use vac in that.
Oh.
In patients whom you have done, for example, diabetic wounds,
Diabetic wound debridement, sir.
debridement, you can use vac. And other thing is, in patients who have undergone long course chemoradiation for rectal cancers, whom you have done AP resection, or in such patients where there is perineal wound, unlikely that it will heal. So you can use vac there.
Yes.
Yeah, okay.
There is no proper recommendation, as there is lack of evidence to assess whether double gloving or changing of gloves during operation or using specific type of gloves is more effective in reducing the risk of surgical site infection.
Pavan, when
Sir.
they say there is no recommendation for double glove, why do we still wear a double glove?
Sir, for surgeons protection, sir.
Excellent. They have found that in as high as 30% of the cases, your outer glove can have small cracks in them, and it's your inner glove which prevents you, or which provides that barrier between the skin and contamination or the blood from the patient. Okay. Second, another point that to be noted here is there is a recommendation that change of gloves and instruments for closing the skin has shown to reduce the risk of surgical site infection. That means, let's assume you're doing a bowel resection, an open surgery or laparotomy. After you finish resecting the bowel, before you start closing the wound, after you've given a good wash, they say change the glove and the set of instruments. Okay, not only changing gloves and using the same needle holder with which you have used for the bowel anastomosis. You can't use the same thing. So change the entire set of instruments. It is shown to reduce the risk of surgical site infections. Go on, Praveen.
So during implants, sir, like mesh.
You don't use implants when you're opening the bowel, right?
No. So if you are using, you are doing
I'm not very sure of it, but I don't think it helps a lot, because if at all you're worried about infection, we are never going to put an implant there.
No. What I'm saying is, suppose we are doing a umbilical hernia mesh repair. So this section we do with one glove, and then for the before we use the mesh, you change the glove. Any recommendation on that?
That's what I'm telling. That a lot of them tell it, but I don't think I've come across any study which tells that in such cases it actually helps. Lakshman sir, Ravi Shankar sir, any update, any inputs?
No recommendation for that.
No recommendation.
Yeah, go on, Praveen.
It is suggested to use triclosan coated sutures for purpose of reducing the surgical site infection, independent of the type of surgery. And there is a suggestion that for perioperative antibiotic prophylaxis should not be continued because of presence of any wound drain for the purpose of preventing surgical site infection. And should remove the wound drain when clinically indicated, but there was no evidence found for recommendation for optimal timing of wound drain removal.
Yeah, so please note that drains per se are a huge topic, which I don't think we'll cover in this. But the idea is, just because there is a drain in place, that doesn't mean you have to continue antibiotics. It's as simple as that. Okay, go on.
There is no recommendations. It is not recommended for any advanced dressing such as hydrocolloid or a standard dressing on primary closed surgical wounds for the purpose of surgical site infection, preventing it.
So none of these fancy dressings are going to help. Yes.
By following this, by preventing the surgical site infection, it is better than the cures of surgical site infection. Thank you, sir.
Okay. Praveen, there is a question which I missed from Pawan. He's asking, what is the difference between prophylactic antibiotics and empirical antibiotics? Do you know the answer?
Sir, not exactly, sir.
Straightforward.
Sir.
See, prophylactic antibiotic is when you're anticipating infection. Even before infection occurs, you're giving antibiotics. Empirical means there is infection, but you don't know where it is. So you start empirical treatment. Like patient comes with fever. You don't know what the cause of fever is, whether it's pneumonia, whether it is pharyngitis. So you give broad spectrum antibiotic. That is called empirical. And once you get blood cultures or wound culture, you're going to narrow your field of antibiotics. So that is empirical. That falls under therapeutic. Prophylactic is even before it occurs, you don't want it to occur. Lakshman sir, Ravishankar sir, was that correct or any changes to that?
Yeah, correct.
I would agree with that. Yeah.
So basically, you have to understand what is the possible infection you are trying to treat. If you are treating urinary tract infection, try and give something that probably acts on urinary tract, biliary tract, say skin, that kind of thing, and or gut. And then once you have cultures to show where the infection is from, then you can change it appropriately.
Yeah. And a very good comment from Nikita. I hadn't actually thought of this. Even if we change the glove, the mesh, what you're going to put is in the same place where you have dissected with the previous glove. So she makes a very valid point that it probably will not make too much of a difference.
Yeah. She also has a question about muck or particulate matter increasing infection. I have not seen specific studies with and without particulate matter, but I think common sense should tell you that it does avoid, because these are these can harbor microorganisms. So
or form a good medium for infection to happen.
Yeah.
Any questions from the postgraduates?
Sir, what is the recommendation, sir? Like application of antimicrobial ointment over the wound. Is there any recommendation, like before or after infection? Antimicrobial ointment, sir.
No recommendation.
No indication for it.
Yes.
Yeah.
Anything else?
Lot of patients ask you. I have never used it myself.
Yeah.
Some
On the
mupirocin has
contrary-
some
On the
positive.
contrary, if you actually use an ointment, you're creating a wet environment there, which is actually a bad thing. You can cause skin maceration and all.
Yeah.
It's better you allow the wound to dry out.
Correct.
Yeah, Abdul, you were about to ask something.
Sir, all topical antibiotics don't work, except I thought it was mupirocin. Which
That is only for nasal. It's not for the skin.
No, for skin, sir. I thought the recommendation.
It's not for skin.
No.
It's only for nasal to prevent, because the commonest area from where MRSAs happen is in the nasal cavity. So you just prevent it. That's all. Not in the skin.
Okay, comments from Pooja and Abdul regarding the class, his presentation and his PPT.
Sir, his slides were very good, sir. It was not very crowded. I think he is not directly read out from the slides.
Thank you. Abdul.
Yes, sir. The class was well made. Slides are better, and it defined what he was about to speak. The slides, and it was quite concise. Something new to learn.
Ravishankar sir, your comments about the class and
Definitely good improvement, Praveen, from the last class. I think the slides were good, and you
Sir,
are not
thank you,
reading from the slide, which is good. I think that is the habit you have to inculcate. And
Yes,
the
sir.
information that you have given was up to date and with evidence, which is again very good. So keep up the good work.
Yes, sir. Thank you, sir.
If I may, just one comment before I give it to Lakshman sir for the closing remarks. One thing I've observed with all you guys, please keep your camera on when you're presenting. Only if you practice here, will you be able to do it much comfortably, either in SSB or in state conference, national conference, or wherever you go next. Okay, so this habit of
Yes,
switching off the camera and so that people can't see your face, it honestly won't help you in the long term. Okay, so I know internet connection and all is there, but it's been 1 or 2 months since we have started. So please make an alternative, get a dongle, something of that sort, because you'll be needing it for the next 2 or 3 years. So you might as well make arrangements for it so that you will improve. Otherwise, the topic was well covered and slides were well made. And what I liked about it is he had actually gone through all the guidelines and he had made it very extensive, and we had to cut it down and just stick to the basics. That's about it from my end. Closing remarks from Lakshman sir.
Yeah, good class. As I have said several times in the last few weeks, please get a good broadband connection. Broadband connection is the cheapest in the world in our country. So please make use of that advantage. Make sure that your connection is good, and it'll help you in every possible way. Slides were good. I have no criticism of the slides. But the one thing, again, it comes from practice, I think. The flow could have been better. And it's a reflection of your junior status. But I think with more practice, your presentation becomes more authoritative. I keep telling youngsters that they should not come with the idea that they don't know. Because honestly, if you've done good reading and you've understood the literature that you have read, you will probably know more than most people in your audience. So while you should not be bluffing, you should not say something that you don't know, or say what you say with confidence. And that is one thing that makes your presentation authentic and very useful. Overall, good class.
Yes.
Congratulations. Thank you very much. Yeah.
Thank you, sir.
Good night, everybody.
Good night.
Good night, everyone.
Thank you, sir.
Good night, sir.